Hello, everyone. I'll just give us another minute or so to get a couple more people in, and then we will get started. All right. Good afternoon, everyone. Welcome to Webinar Wednesday today on April 16th, 2025. My name is Madison Lohman. I'm the Member Program Coordinator here at Digital Health Canada, and I will be your host today. I would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we all call home. We gratefully acknowledge that we are on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, the Williams Treaties signed, and the Williams Treaties signed with multiple Mississaugas and Chippewa bands. Please share in the chat the territory you're joining from. Today's webinar is Clinician Voices as a Catalyst for Change, exploring the recommendations of the Digital Health Interoperability Task Force. I'd also like to note that this session is part of the Webinar Wednesday Healthcare Innovation Round series and has been certified for Main Pro Plus credit. It is my pleasure to introduce Dr. Rashad Bayat. He is an award-winning family physician with special expertise in health informatics and digital health, and an accomplished medical communicator. He is senior clinical leader in the Center for Clinical Innovation at Digital Health at Canada Health Infoway. Recently, he co-chaired the Digital Health Interoperability Task Force, a joint initiative of the CMA, CFPC, Royal College, and Infoway that released its report and recommendations in the fall of 2024. He also co-chaired the CanMEDS 2025 Data Informed Medicine Working Group for the Royal College of Physicians and Surgeons of Canada. Currently, he practices in an EMR-enabled family medicine clinic in Brampton, Ontario. On a technical note, please note that we will have time for Q&A at the end of today's presentation, so please type your questions in the chat or in the Q&A section at any point. Thank you to Dr. Bayat for being here today, and I will now pass the screen over to you.
Thanks so much, Madison. I'm just going to start sharing the screen here. Hang on 1 minute. Here we go. Okay, so just want to double check that you can see the PowerPoint okay and that it's in presentation mode. Fantastic. Okay. So we'll get started. Hello, everyone. Bonjour tout le monde. So my name is Rashad Bayat. I'm a family physician, as Madison said, with special expertise in digital health. I want to extend a huge thanks to Digital Health Canada, the Webinar Wednesday committee, especially Dr. Alexandra Greenhill, for the opportunity to speak with you today, and to Madison as well, to speak to you about a major clinically focused thought leadership effort that Infoway and 3 clinical partner organizations undertook in 2024. The Digital Health Interoperability Task Force report and recommendations, which are intended to continue the momentum on advancing connected care or digital health interoperability in Canada. And this presentation is intended to speak a little bit to why we're all here in this industry working on problems related to connected care, and why we need to work on solving the challenge of connecting systems in a seamless, modern manner to the benefit of patient care and clinicians. So thanks, Madison, for the land acknowledgement, and I'll just acknowledge that my home base is in Toronto on the traditional and ancestral lands of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and the Wendat peoples. The disclosure. So I am a part-time employee of Canada Health Infoway, a federally funded not-for-profit organization. Oops, I think I may have missed the, hang on 1 second. May have missed the learning objectives. So these are the learning objectives for today. I think you might have received those in advance. A tiny bit of background about Infoway, just to set a bit of context. So for those of you not familiar with us, Canada Health Infoway is an independent, not-for-profit organization federally funded through Health Canada. We were established in 2001 to accelerate the adoption of digital health technologies across the country. The next two slides aim to provide a bit of context of the digital health landscape in Canada in 2024 and 2025 that set the backdrop for the Digital Health Interoperability Task Force's work. So Infoway's evolution really mirrored Canada's digital health transformation journey over the past 2 decades. It started as a strategic investor in the building blocks of provincial and territorial electronic health records, moved towards funding digital tools and change management programs for clinicians focusing on EMRs, as well as telehealth and remote patient monitoring programs, as well as partnerships to advance clinician education in digital health. In 2017, we evolved to operate a national electronic prescribing service, Prescribe It, which some of you may have heard of. And then in 2020, we pivoted to help the provinces and the territories fund virtual care initiatives through the pandemic. And now exiting the pandemic, we've moved towards a renewed focus on enhancing standards-based interoperability to support connected care. So this shared pan-Canadian roadmap was approved by the Council of Deputy Ministers, and the roadmap is intended to bring the provinces and territories and Indigenous communities together around common pan-Canadian goals, in this case, 4 key pillars, with short-term specific actions supporting those pillars: addressing data portability in primary care, improving provider access to patient data at the point of care, enabling patient access to their own records, and improving care coordination and collaboration, essentially supporting pan-Canadian standards on tools such as e-referral, e-consult, and the patient summary. I should also note that other peer nations around the world have similar interoperability roadmaps, including, for example, Australia and New Zealand. And critically, this work involves partners CIHI, Statistics Canada, our funders, Health Canada, and more. And another key point is that this roadmap is evolving. So this is a glass half full slide. Despite all of our challenges, most physicians, nurses, and other clinicians now practice in digital environments, reflecting a massive system transformation over the last 20 years. However, digital health in Canada has evolved in a complex and chaotic manner, with many challenges downloaded upon physicians and other clinicians. Uh, frequently without their input, to the detriment of their own mental health and sometimes to the detriment of patient safety. Meanwhile, Canada is facing multiple large challenges in healthcare exiting the pandemic, in addition to new political challenges outside our borders. So clinician burnout linked to administrative burden, particularly in primary care, exacerbating a health human resources crisis. The interoperability gap. A lack of true interoperability of health data exists, with siloed systems that have proliferated in an uneven digital transformation over the past 20 years. Patient safety risks. The harm to patients is real and growing, in large part due to the interoperability gap, and this has been highlighted in reports such as the Interoperability Saves Lives report and by our task force report. So in a few slides, I'll try to paint a picture of the challenges that physicians face regarding disconnected care in Canada at present. And these findings come from our 2024 physician survey results, a partnership between the Canadian Medical Association and our Infoway performance research team. So huge thanks to the performance team. The survey assessed physicians' perspectives on the use and impact of digital health technologies in practice. And for the audience, you can access this survey as well as our nursing survey and many other of our research initiatives all online through the Infoway Insights website. So again, another glass half full slide. Nearly all, 95% of physicians are using EMRs or EHRs, a significant increase compared to 87% in 2021 and 82% in 2017. However, we get to these slides. I think that this slide will resonate with most of the audience. Nearly 7 in 10 68% of physicians say they spent an hour or more beyond what they feel should be spent looking for patient information needed to provide care during a workday, with over a third saying they spent 2 hours or more. On average, docs spent 86 minutes beyond what they should to find patient information. So a pretty shocking figure and an indication of the challenges in the current state. Like the last slide, this one too is shocking and is the so-called pajama time finding. The average time spent on an EMR after a typical workday by physicians who use an EMR was 107 minutes, and 51% spent 2 hours or more. So all of this leads up to the next slide, which is about burnout. Nearly half of physicians, 44%, are reporting feeling burned out to some extent, with 5% feeling completely burned out. And this is an ominous finding in the context of mounting challenges with difficult to use digital tools and low levels of interoperability. So now back to the task force. The Digital Health Interoperability Task Force is a partnership of Infoway and the three leading national physician organizations, the CMA, the CFPC, and the Royal College of Physicians and Surgeons. It brought together 17 senior physician leaders from across the country with experience and understanding of the digital health landscape, along with nursing representation. A huge thank you here to Dr. Ed Brown and our secretariat team for driving this forward at every step. I was very fortunate to co-chair the task force, as Madison mentioned, with Dr. Samuel Ogunbi, my excellent co-chair from the Royal College, and the goals are listed in the next slide. In summary, the task force had three goals. The first goal was to provide a physician perspective on the current state of interoperability or lack thereof in Canada. We had not heard from the docs yet at a national level on this subject. It was also to stimulate approaches and innovations to overcome key barriers and to ensure that, that the implementation of interoperability linked tools is practical at the front lines of care. The work of the task force is reflected in a final report with the great assistance from Pat Rich, thank you, Pat, released in November of 2024. The task force identified many examples of interoperability challenges. Here are some of the challenges. There's many of them, so I'll highlight a few in the interest of time over the next two slides. There are technological challenges such as non-integrated portals requiring multiple sign-ins, many searches, and manual processes. There are policy-related challenges such as the absence of legislation mandating technical interoperability standards. There's also the clinician burden challenge, which we alluded to in the findings from the survey results. The challenge of limited education and training supports. Doctors are still not receiving adequate education about digital health tools and how to use them in practice. And this also, goes for other professions such as nurses as well, which we found in our nursing survey. As one of the task force members noted with great insight, doctors and nurses and others are not going to be data entry clerks, even if you pay them. So we get to the recommendations now, and here they are. These are 5 concrete recommendations that represent a necessary next stage in the evolution of the healthcare system. They outline tangible steps for decision makers to take with embedded accountability. So recommendation 1, we need a well-defined plan and we must move faster. Federal, provincial, and territorial governments should commit to developing and fast-tracking a comprehensive plan that will deliver tangible improvements in interoperability within 5 years. The plan should be developed and its implementation overseen through the immediate establishment of a collaborative National Health Data Governance Council. Recommendation 2 is to accelerate policy to advance interoperability. And I'll touch a bit more on this one a little later. The necessary policy and legislation work underway at the federal level, to drive comprehensive interoperability of health data in Canada should be accelerated and supported by provincial and territorial governments. This includes legislation to mandate the data and technology standards required to support clinical data exchange and transactions, such as envisioned in Bill C-72, rest in peace, and whatever may come in its aftermath. A national framework for modern health data stewardship policies that champion appropriate data sharing, access, secondary use, and privacy protection. And this must include formalization of Indigenous health data sovereignty policies as determined by Indigenous communities, engagement with the public, clinicians, and other partners to co-design the national stewardship framework and promote communication of these policies to engender trust with the public and address privacy concerns. Requirements to ensure that patient ownership of and digital access to their health data is continuing to occur. So recommendation 3 is really about you forgot about the doctors, you forgot about the nurses, but in this case you forgot about workflow. Provinces and territories really need to commit to addressing the key barriers preventing physicians and other healthcare professionals from participating in health data interoperability related initiatives by ensuring that health data solution deployments that impact clinicians are co-designed and include a cross-section of practicing clinicians in a meaningful manner. Also, ensuring that the process for every procurement that impacts clinicians includes evaluation of the end user experience, workflow, and the clinician burden. This must be a critical criterion. Co-developing a digitally enabled strategy and roadmap within each jurisdiction aimed at measuring and reducing clinician administrative burden and optimizing clinician workflows. Uh, And sorry, I should have mentioned, last but not least, in recommendation 3 is ensuring that the administrative burden and the cost of interoperability initiatives are not downloaded to clinicians. So recommendation 4 is really about organized medicine continuing to be actively involved. Organized medicine represented by national and/or provincial and territorial medical associations can and should continue to play an important role in providing guidance and support for physicians on interoperability by continuing to develop best practice guidelines that assist physicians in engaging in a digitally interoperable environment in the context of improving patient care, and also advocating and working collaboratively, with government to implement regional strategies to remove the barriers to interoperability identified by the task force, including workflow, training and resourcing needs, and interprofessional care. And recommendation 5 we'll touch a bit upon later as well in a bit more depth. And this one is really continuous innovation through research and development. Canada's research and development funding organizations should commit to investing in continuous innovation in digital health that overcomes critical barriers to interoperability by developing new strategies in activities such as data standardization and curation and report generation from EMRs, leveraging artificial intelligence-based tools and technologies that better support clinician participation and simultaneously reduce their workload. Additionally, addressing current challenges with EMRs for healthcare teams' needs. Okay, just went to one slide too far there, sorry. So again, the task force presented these 5 concrete recommendations, which represented this next stage of evolution in our complex healthcare system. Infoway, with our sister organization, CIHI, our funders, Health Canada, and other partners are working on advancing recommendation 1. The CMA, the CFPC, the Royal College, and Infoway are continuing to meet since the recommendations were released, and there is commitment to advocating for recommendation 2, a supportive legislative and policy environment in particular, working on the human factors of interoperability. And this is especially important since Bill C-72 died due to recent political changes, including, the announcement of the federal election. However, action will require the coordinated work of many hands. I've starred recommendations 3 and 5 because in the next few slides, I'll cover a few initiatives a few initiatives and areas where Infoway and partner jurisdictions and organizations are attempting to make a positive impact. So this slide is really about how do we prevent the recommendations from becoming shelfware? dreaded shelfware. So, number one, maintain momentum in the face of adversity. Based on political changes in just the past couple of months, as I said earlier, Bill C-72 is no longer with us. However, we must continue to advocate in a nonpartisan manner for something to rise from its ashes for the benefit of all Canadians. We must take incremental steps towards action on the Digital Health Interoperability Task Force recommendations, working with partners specifically. So one example is addressed in upcoming slides, the AI Scribe Investment Program, where we will aim to scale and spread a useful, novel technology in primary care with a goal of moving from basic scribe technology to more advanced integrated tools that lay the foundations for improved data quality, automated data extraction, and standardized data collection with formatting, and greater standards-based interoperability overall. Third, we must continue our efforts to make it easier for clinicians to participate in a digitally interoperable healthcare system, ultimately enhancing patient safety and care. So, for example, we must try to advance initiatives like the HALO project, which I'll touch upon later, which aims to standardize the primary care user interface. We should also support efforts, as mentioned earlier, to involve clinicians in the co-design of initiatives. So I'll mention the CIDH, the Center for Clinical Innovation in Digital Health, very briefly in the context of taking action. The CIDH is really a vehicle within Infoway to help advance recommendations 3 and 5, believing in the art of the possible and supporting clinician digital health innovators on the front lines of care through on the front lines of care. The CIDH was intended to have a small clinician engagement team to provide subject matter expertise and strategic guidance to internal teams and external partners, but also to work with key clinical partners, including professional organizations, to inform, shape, and raise awareness of connected care generally across the country. The activities support both the Pan-Canadian Interoperability Roadmap and action on the task force recommendations through programs like the Clinician Innovation Grant and the Clinical Student Scholarship Program, which I'll mention in the next slides. Oops, sorry. These clinician innovation grants were just a twinkle in the eye about a year and a half ago. And when I pitched the idea to leadership, I was inspired by seeing clinical colleagues, physicians, nurses, pharmacists coming up with and or implementing unique and interesting technological solutions on their own with minimal supports. And I suspected that there might be clinical innovators out there whose ideas could advance interoperability, enhance patient care, and might just need a bit of a boost. And so our team was quite blown away by the response. We had over 100 applications. These are all grassroots, potentially scalable, clinically oriented initiatives that demonstrated the value of connected care. Infoway provided $450,000 in total funding across 10 winning applications, and a number of these initiatives involve, I should say, AI-powered tools. We're hoping to run the program again this year, so stay tuned, with a greater focus on delivering recommendations 3 and 5, aiming to make it easier for clinicians to participate in a digitally interoperable environment. Another piece of our CIDH is the Clinical Student Scholarship Program. The scholarships are a longer-term play in the sense that they are intended to build capacity for our next generation of clinicians to both advocate for and lead improvements in connected care. The scholarship awarded up to $5,000 per student to support clinical learners in advancing their digital health education, and Infoway awarded 17 students with the scholarship, total investment of more than $75,000. The students come from a diverse set of clinical backgrounds, including medicine, nursing, and pharmacy, and represent professional schools from across the country. So again, with the scholarship program, stay tuned. We're hoping to continue the initiative for this year into next year. So at last, this brings us to the AI Scribe Investment Program, which again is one of our efforts to take action on the recommendations of the task force. We know the problems well, as we illustrated in the physician survey and the earlier slides, and were highlighted as well by the task force. This is one potential part of the solution, again, looking at the recommendations, really focusing on recommendation 3 and recommendation 5. Infoway and our partners, including Health Canada, see an opportunity to both improve the administrative burden on physicians using and other clinicians, including nurse practitioners, using a novel tool, AI scribes, but also to advance better EMR data quality, standards-based interoperability of data, and improved analytics in primary care and beyond. Scribes, for the sake of scribes, could be a waste, a shiny toy that has limited adoption without the right value attached to it. So our program is attempting to articulate a vision of maturity of AI scribes, moving from just basic AI scribes towards AI scribes plus, tools that not only assist with documentation, but eventually integrate with EMRs, help to extract data from our SOAP notes in a standardized format, such as the patient summary format, a national standard for a patient summary based on an international standard. The data can then be used in other forms of data exchange and workflows. And we're hoping to move the market towards greater innovation with these tools, making them more readily accessible and really reducing administrative burden, especially on family doctors and nurse practitioners in primary care. So on this slide, you can see our target clinical audience here. We are aiming to reach 10,000 primary care providers, family physicians, NPs, registered nurses in remote communities, and pediatricians who provide longitudinal care in the community. There is a QR code link here to our sign up page if you're interested. But before I wrap up, I really do want to touch very briefly upon the HALO project, which is this next slide here. It's an initiative that's very close to my heart as a family physician and is another move forward on actioning task force recommendations, specifically number 3. There will be another Digital Health Canada webinar on this topic in the future, as I understand. So this is just a teaser. And remember that our Digital Health Interoperability Task Force identified barriers to physicians participating in a connected system. One major challenge is the multiple non-standardized EMRs that we have in Canada with few connected care options, which present challenges to implementing coherent provincial and territorial and Indigenous e-services. In a nutshell, Halo is an app launcher feature that would connect all EMRs to provincial, territorial, or Indigenous digital tools using a single set of pan-Canadian standards. In one click, providers could launch the e-referral or e-consult app, an immunization record, for example, or a view into a provincial electronic health record, or request or send a standardized patient summary. It's plug and play like the Apple App Store or Google Play, and it's in the field both in BC and Ontario as we speak. So interesting, keep an eye on that space. And so I'm just looking at the time, Madison, it's 12:28. So I'm going to move over into our next phase here. And just in summary, keeping up the momentum on enhancing connected care will require the efforts of many partners. But I do believe that we have reached a tipping point in this enormous task and that we can make it easy for clinicians in the future to operate at their highest level in a digital environment to the benefit of patients. The recommendations that I've presented here today are one piece of the puzzle, only one piece, and they outline tangible steps for decision makers to take with embedded accountability. As one of our Digital Health Digital Health Interoperability Task Force members said, perhaps the recommendations will act as a North Star, guiding us for a period of time. I do want to thank all the clinicians who participated in the Digital Health Interoperability Task Force. There are 17 of them, so please check out the report and you'll see who all of them are. But at this point, I'd like to open the discussion up to the audience. I'm interested to know, what are your thoughts on how can clinicians be best supported to participate in a digitally connected healthcare system? And what are your thoughts on the path forward?
Awesome. Thank you, Rashad. We do have a couple of questions in the meantime. Maybe we can get to those before we get to any discussion too. Just quickly, we have had a question about if we could get the QR code. Is there somewhere that you can either put it up on the screen, or is there somewhere that they can contact you to get the QR code?
Sure. So let me just flip back to the QR code. How's that?
Perfect.
Okay, great.
Maybe we'll just keep that up there for a second or two and people can scan, and then we can go back to the discussion slide after.
Sure.
We do have another question here, not QR code related. We have one from Melissa that's asking if you could maybe share any more information about the AI Scribe investment program. I know you talked a little bit about it, but are there any other details that you'd like to talk about there?
Sure. I guess the first place to start is that it's intended to launch in for clinicians to be able to sign up through our landing page. You can sign up right now, but it's intended to be active for clinicians towards May, June, probably closer to June at this point. But the first step of the process in the program is an RFPQ process in which we've had AI scribe vendors focusing on primary care apply to have their solutions evaluated and vetted based on a set of criteria and standards that we are hoping establish a certain benchmark for quality of the product within Canada. So that process is underway. There will be a list released working in close coordination with each province and territory to make sure that this is highly complementary to their wishes for their clinicians in their province. So this is not something that supersedes any provincial or territorial activity because, for example, I'm in Ontario and Ontario is working on their own program, and they've had their own RFP process, and we are very working in tandem with them to support how their clinicians will be supported and funded through the same in the same way, but in a slightly different tailored manner for each province and territory. So that's how the program is intended to work. Um, it will provide family doctors and nurse practitioners and others with a choice, ideally a choice of scribes, but this depends on the province or territory that they're operating in at the moment. But the idea by vetting those scribe solutions is that there is a set of solutions that we know meet a certain set of standards from a clinical perspective. Remember that whole discussion on co-design earlier and engagement. So we've had clinicians weigh in on every step of this process to try and make sure it's very focused on how these products will work and how well they do work right now at the clinical coalface.
Awesome. And we do kind of along similar lines to do with the AI scribes. We have had an anonymous attendee say, I appreciate the step towards AI scribes, but a lot of physicians or clinics do not want to use them due to the extra cost posed by EMR/EHR vendors. What is being done to address the added costs and about addressing current workflows and support physicians with training?
Yeah. So it's a very good question. A lot of those considerations have been baked into the program. It is moving fairly quickly, but first, the question of cost. So I myself practice in a what could be called a fee-for-service plus type of practice and completely understand the additional cost burdens that these products can potentially add to one's overhead, which is challenging and is really part of the burnout issue that is facing primary care at the moment. And so a lot of the internal advocacy that I've been doing and with others is to note that yes, we are funding the scribes for up to 12 months, but we really have to uh, consider what happens after the 12 months. Otherwise, we can potentially have a repeat of past challenges around these kinds of solutions. And so part of what we're doing is a robust evaluation, working with researchers to follow how the impact of the scribes on clinician practices, on clinicians themselves, physicians in particular, as well as we're also measuring the public's response through our survey of Canadians as well. But the idea is that the evaluation should help to inform policy and continuation. So theoretically, if there's a solid benefit seen from these scribe tools, really it should encourage provincial and territorial partners to really consider longer term funding approaches and embedding them into existing supports. There are change management supports built into this program. Again, they are tailored to each province and territory. So really the provinces and territories determine how they would like to additionally support their own clinicians in that region. We will have some national resources and tools to uh, give clinicians a little bit of extra support on how to implement these tools. I myself have gone through an implementation and have been providing a lot of this feedback to our team. It's not completely straightforward. It really depends. The change management aspect is part of the secret sauce, and you really do need a champion in each practice, ideally a clinical champion or an MOA, a medical office assistant or manager champion to work with clinicians closely on how best one of these tools might fit into your workflow. And, it may work perfectly in some existing setups, and it may require some adjustments in others. In my case, it required a few adjustments. And so that took a bit of time. It takes a lot of thinking. And for busy clinicians who are, right in the middle of their practices and busy days and don't have a ton of time, that is an additional consideration. So there are some resources that we will provide. There's also some excellent resources out there already. Ontario MD has some great resources. The Center for Effective Practice has some excellent resources right now. So if you're thinking about it, I would advise you to, have a look at some of those resources, including some of the quick videos, because they give you an overview of what's involved. The good news is when you're looking at an EMR implementation, say 10 years ago or even more recently, the learning curve for adopting an ambient AI scribe in primary care, the learning curve is a lot less steep than adopting, say, an electronic medical record from scratch or a clinical information system, hospital information system from scratch. So that's the good news. But it's never 100% an easy path. So really great question.
Awesome, thank you. I'll continue on the topic of the AI scribes. We have one more question that just came in from Heidi. What consideration is the AI scribe program giving to privacy requirements in each province? For example, the legal requirement for a privacy impact assessment before implementing an AI scribe in Alberta.
Yeah, so that's a great question. I did answer this in a small way earlier. So through the RFPQ process, Infoway's privacy and security team have established a very high standard in terms of benchmarks for privacy, security, data management, data data storage. All of those pieces are built in, so the scribe tools that make it through that process have already met a certain benchmark in terms of the product itself. Now, then it comes down to each province and territory and their individual requirements. So it really depends what the province and territory intends for its own clinicians. And there may be, additional considerations vis-a-vis, PIAs, that kind of thing, which each province and territory would take on. We are there obviously to support them, but there is some individualization. But you can be reassured, we all should be reassured that these tools have been vetted so that they are very well in line with current privacy and security related legislation provincially, nationally in Canada.
Great, awesome. And we'll shift a bit to away from the AI scribes for another question. We have one from Scott. He says, "Thank you very much for the presentation. He really appreciates it. Does Halo relate to other broadly adopted standards like SMART or FHIR for launching third-party solutions in the context of an EMR?"
Yes, yeah. So that's a great question. Yes, the short answer is yes, and you can see me getting very excited about this because it is leveraging um, well accepted standards. Now, again, I think you should stay tuned for the Halo presentation because they'll have architects and some of our technical team who would be on that in that presentation to provide like a much deeper dive there. But one of the big challenges right now is that not all, a number, many EMR vendors are not necessarily all using the same set of emerging accepted standards such as Smart on Fire. And that's not a knock against any of them because many of them have been doing amazing work building products from an early stage when those well accepted standards in 2025 may not have been in existence or may have evolved from something else to where it is now. So sometimes, there's a need to um, try and align these parties. So you have the provincial and territorial and Indigenous e-services who may want to use one set of standards that's now accepted, and you may need to bring the other group up or align them. So that takes a bit of time, a lot of legwork, a lot of technical insight, which is not my wheelhouse. But I think you should stay tuned because what it is moving towards is a set of standards that theoretically in the future EMR vendors can build towards, and that provincial, territorial, and Indigenous e-services can also build towards, knowing that, okay, if we want to activate this service, there's a simple set of standards, whether it's Smart on Fire or a bridge to Smart on Fire or something that is in the middle. And that eventually we're going to get to that one point where we can all plug and play. So that's the vision. It's starting off again with limited production releases, but I would definitely stay tuned for that deeper dive with the team who knows the most about it.
Awesome, thank you. And we have another question here from Kirk. What are the incentives in your program for EMR and EHR companies to be aligned with connectivity standards?
Yeah, so you can check out our RFPQ, which can be found through Infoway's website. It's publicly available. It's under Doing Business with Infoway, and it'll lead you to the actual RFPQ documents. But there are some incentives to help with the integration pieces, and we're looking at future phases of this potentially. So again, all of this is highly dependent on how the initiative goes, how it's received by not just clinicians, but industry, as well as provincial and territorial partners. And in the mix in all of this are political and fiscal uncertainties. So stay tuned. That's the plan. The idea is again to try and move our thinking from standalone products that are great, but are potentially, could really benefit from some incentivization to be more integrated. Again, going back to those task force recommendations and looking at it from the clinical and patient point of view. If you are a clinician, do you really want another set of logins that you have to deal with? If these tools ultimately are integrated with single sign-on and are smooth and part of your integrated user experience and interface, that's where we want to go. That's where the digital doctor, the digital nurse practitioner of the future will be. And I think we will actually see an interesting evolution of the primary care EMR space towards something that will actually encourage young clinicians to come into family medicine rather than leave family medicine. And enter into, to become primary care nurse practitioners as well. So hope that answers the question.
Awesome. And we have another question here from an anonymous attendee. It is my impression that the traditional EMR vendors have been part of the interoperability problem as they have not been incentivized to invest in interoperability. With C72 gone, it seems like vendors can continue dragging their feet. Are there any new EMR vendors that are fully embracing the use of open standards?
Yeah, so it's a bit of a loaded question. I'm not really going to comment on EMR vendors as part of the problem. I think, there are many partners across the country in the private sector, public sector, who've been working towards common goals. I will absolutely agree with the fact that incentives have not always been aligned, and at the territorial and national levels. And some of that is in part due to the nature of Canada's federation and just how Canada works, vis-a-vis healthcare. However, having said all that, it's a really good question, and it raises the point, around incentivization. Um, we did see when we saw the last big movement of the dial on adoption of a technology in healthcare. um, I'll use primary care as an example. It really was the EMR incentivization program, which was a partnership between the federal level through Infoway and provinces and territories, sharing that funding to try and incentivize physicians, in particular in primary care, to adopt EMRs. It was imperfect, absolutely, and anybody who's in family medicine knows that. But it did achieve one goal, which was moving the needle on getting computers into offices and getting doctors using technology. Highly imperfect, highly challenging, and that journey is still not finished. So that's where we really have to try and realign incentives and work towards listening to clinician voices in terms of what works well for them, to improve patient care, to improve sharing of information, to improve team-based care, interprofessional care, all of those pieces, which is what we're moving towards in the future. So hope that helps. It's a very complex issue.
Yeah, for sure. And we have one more question here from Pascal. They say, thank you for your presentation. Can you share a few more details on the Halo project? Are there plans to facilitate standardization and optimization of user interfaces and workflows of the connected systems?
So yeah, yes. Again, lots of contingencies, and I would say stay tuned for the presentation on Halo because you'll get a much deeper dive into Halo at that point. The one thing you could do at this time is potentially check out Infoway's Info Central website, which does allow the general public and partners from industry, private sector, public sector to come together in open forums relating to some of the standards that we are working on. And so you could potentially sign up there and see if there's um, one group that may be one that you'd want to stay in touch with. I think the Halo presentation should have a lot more information that would be useful to you. Um, I'm also going to come back to what I said earlier, which is we are entering a time of additional change and uncertainty and headwinds. And so, it's very challenging to know what could be done without knowing where those uncertainties may lie in the future.
Awesome. And we have a question from Ash here. What are the areas you see the major gaps and wish partners slash vendors could fill in?
Again, I'm going to read into that question. Major gaps in interoperability. Is that what we're?
There wasn't anything specific, but I would assume that that's what we're talking
Yeah,
about. Yeah.
yeah. I mean, what I, one of the areas for vendors, I should say, really it's all partners, but if you're building a new product, for example, or you're trying to evolve a product that exists, I mean, you really have to come back to that co-design point and try to, you know, almost sit at the elbow to find out what the challenges are. The Digital Health Interoperability Task Force report outlines a lot of those challenges in detail. And some of it is user interface and user experience related challenges, but some of it are challenges that are beyond what the vendors necessarily have control over. So, there's certain things that you can work on with co-designed, with clinician co-design and patient co-design, depending on what the tool or feature is. Uh, some of those things, through co-design, you can actually figure out how certain tools and features should look and feel when they are being accessed to reduce the click burden, to reduce, flipping between screens, those kinds of challenges. But there are some things that are more challenging for that vendors may not be able to address easily, right? And those could be the connection points with services they're trying to engage with, which are still heavily fax and paper-based to some extent. But we are seeing a lot of movement in provinces and territories away from that, which is fantastic to see, really fantastic to see. There's definitely a momentum happening at multiple levels from multiple partners around thinking around how do we replace a service or a process that was pretty clunky, and with something that's smoother. And you really have to walk through it with the clinicians and the implementation of it with clinicians. I've seen this myself with tools like e-referral and e-consult and e-prescribing. All of those tools are not brand new. They've been around for years, but why are physicians not using them? Why are NPs not using them en masse? Well, you can dig down into user experience issues, user interface issues, implementation issues, right? And you may want to start with one small problem and make it amazing, and then move on to the next one. It's hard to deal with all of them at the same time. So, you could have a whole separate session on this. And there are researchers across the country who are working on this as well. So, hope that helps a little bit.
Yes, for sure. Sorry, I got lost on my screen there. Okay, we have another one from Ryan. As this has evolved, have you seen any hesitation from physicians in sharing the information that is within their EMR with other care providers? For example, provincial health organizations, and if so, how do you see this being worked through?
Yeah, these are great questions. This one in particular. Uh, so a lot of it has comes down to engaging with clinicians and addressing fears early on, and looking at the bigger picture. So it depends on what you're talking about sharing. So when we get into, say, for example, a patient summary, clinicians, physicians in particular, in family practice, we capture what in the standards world, it's referred to as a patient summary. It's based on an international patient summary. It's basically a snapshot of your patient record, a snapshot in time. And you can visit our website, you can visit IHE's website as well to see more on that. But we've already been capturing that in our EMRs. We just call it something else. We call it the cumulative patient profile or the patient history. There's in different EMRs, it's called something different. Uh, so the question is most of that information shareable? So one thing to consider is that for most patients, I would say already think that that information is shareable, or is shared within the circle of care. Um, but there are sensitive pieces of that information that physicians and patients are uncomfortable sharing, and those are the parts that need to be addressed when you're having discussions in each province and territory on how that patient summary is generated. So there are some patient summary initiatives ongoing right now in Canada in a few different provinces that are getting early feedback on physician perspectives on the patient summary and patient perspectives on the patient summary. Uh, by law, a lot of that information is essentially the patient's information. It's just being held in a custodial fashion by the provider in under our current legislative structures and policy structures. In one province in New Brunswick, they've taken a patient-centric approach to the patient summary right out of the gate, and they've leveraged their provincial portal to provide patients who log into their patient portal with a snapshot of their patient record available from a few different data sources within New Brunswick, providing that patient summary as a snapshot in time. And so that's a more direct approach to providing that information and having it readily available as a patient when you transition between points of care. Now, I think most physicians and nurses and other clinicians would understand that there's a certain subset of information that could be extremely valuable and provide safer care if it was transitioned and moved with the patient as they journey through the system. And so I think, a lot of education and engagement around that can help to alleviate some of the fears. And if clinicians, again, are engaged at every point along the way, it's helpful to identify, points at which there may be red flags in terms of how a technical solution is not entirely reflecting what the clinical and patient considerations are. So that's a long way of saying lots of engagement will help because this is an emerging and new space, and we are trying to establish best practices based on what exists, but also based on what is to come.
Awesome. Well, thank you very much, Dr. Byatt. I think that will be our last question for the day. If anybody else has any further questions about anything, I'm sure they will be able to get in contact with you and you can talk to them about it. I'm just going to share my screen again and I will pull up our satisfaction poll. If you guys could please answer the satisfaction poll that is on your screen. It really helps us to learn about your opinions on how our webinars go. It helps us to shape future ones, and we hope that you enjoyed.
Thanks again, Madison, and thanks to Digital Health Canada. Really appreciate the opportunity to join you and to just have this discussion with you. And thanks to the audience for the engagement and the great questions. And stay tuned. There are lots of different organizations and partners working in this space across the country. We are but one, but we are working with our partners to try and keep moving the dial forward on better connected care for Canadians.
Awesome. And we also have this satisfaction survey that you can go to here through this QR code, and that can help uh, us know about your opinions on our healthcare innovation rounds, and it will help us with those future webinars as well. So please follow this QR code, take the 2-minute survey. It's not very long. We would really appreciate that. Next, a couple of things. Just we have our Digital Health Canada members online community. If you are a member of Digital Health Canada, you can log into this community hub and talk to other members. You can join working groups. You can access resources, including all of our Webinar Wednesday recordings, both past and future. So check that out if you're interested. If you're not a member, you can join us and become a member and gain access to this online community. And finally, we have our upcoming event, which is eHealth 25. It is, oh, sorry about that. It is in Toronto from June 1st to June 3rd. You can sign up for eHealth 25 up until the day before, which is May 31st. So please join us at this Digital Health Canada event. We look forward to seeing you there. And once again, thank you very much to Dr. Byatt, and thank you all for joining us today. I hope you have a lovely rest of your day.